I'm Dr. Michael Natola.
And I'm Megan Strong.
It's an all-request case of the week, and the winner is implant overdenture.
And we'll tell you about how Texas does its residents a solid.
And a New York dentist files a tax return asking for a $35 million refund. He's got solid for brains. That and more on today's Chairside Live. Welcome to episode 97 of Chairside Live. Megan, how you doing today?
I'm doing well. Today is the first day, because you all care, I'm sure, the first day of my third trimester.
Oh, really?
And the thing that I have to report is that I'm officially upset because my fingers have been swelling and my ring doesn't fit anymore. So I had to take it off with a vitamin E oil because it would not come off on its own.
Wow. Well, at least you got it early. You didn't have to do like the jaws of life at the hospital because your finger was turning purple or anything like that.
But other than that, I'm good. How are you doing?
So now you're walking around without a wedding ring and pregnant.
Yeah.
People are judging left and right.
And I look so young. It's like there's that teenager just unwed, another one.
Right.
Here she
MTV's
is.
going to start following you around wanting to make a reality show soon.
Pretty much.
Well, we've got an interesting case of the week for you this week. It's an all-request case of the week. Doctor wrote in and wanted to see what a implant overdenture on some locator attachments would look like, and so I thought we would walk you through those steps. Today's case of the week is actually a request. A doctor wrote in and said, hey, can you go over the steps for placing a removable lower denture attached to implants with zest attachments? So zest or locator attachments, as are more commonly known. So yeah, we'd be happy to do that. So first of all, if you haven't seen a denture like that before, this happens to be a full lower denture. And as I take this off of here, you can see the 4 locator abutments that are in place. And even though this fictitious ridge, has a fair amount of height, then maybe a lower denture here would work. One of my lower dentures certainly would not work there. And so as a result, being able to place 4 of these locator abutments on top of implants is an excellent way to be able to get some additional retention and really retention, period, so that the patient can have a lower denture that feels somewhat like the upper. You can see the locator rings that are on the inside of these, the locator caps. These are the black processing caps that aren't going to actually be used once everything's done. There's a couple different retention strengths that you can choose from. 3 of them actually ship with the case. There's a clear one that has 5 pounds of retention, a pink one that's about 3 pounds, and a blue one that's 1.5. And that's pretty much where I start most of my patients, is with the blue one. And actually most of them are pretty happy with the blue one, which is what Zest calls extra light retention. But some people, we will move up if they don't like that and go to the pink, which is twice as much. But people don't like to break nails, trying to take this out or trying to, strain too much as they're doing this. So how do we get to this point, I think, is what the doctor was asking. And so let's take a look at a case here and see how we get to this point. So we've got a patient with their 4 implants placed, for example, in the maxilla, and we've got our healing caps in place. And the first thing we're going to do is just take an impression of this, really just to make a custom tray. So just take any type of preliminary impression here, and polyvinyl is typically the best way to do this. With a plastic tray is fine, doesn't need to be a metal tray. And you can just take something like this, and we just need to know the contours for the custom tray. And so on the second appointment, we're going to send a custom tray back to you. And we have a preference, or I have a preference, I should say, for an open tray technique like this. So these are open tray impression copings that have now been seated down onto the implants, and we'll take a quick digital x-ray to make sure those are seated all the way. My preference for these just kind of stems from the fact that when we look at double arch impression trays and we pour up those models, it's really difficult to get the model to go back into the polyvinyl. Sometimes you can get it to seat all the way, sometimes you can't, and I kind of feel that same way about closed tray impression copings, trying to get them to seat back in there. You think they're all the way in, they look like they are, but this seems like a much safer way for me, to be able to do it and know that I've picked up those impression copings. So we've got the impression coping, and then we have a guide pin that screws it down into the implant, and so we're going to try in our custom tray and make sure that it doesn't interfere with any of those impression copings, and then just take our custom tray impression and smear off with our finger the impression material on top of those so we can see the guide pins. Let the impression material cure completely, and then loosen the guide pins and lift the impression copings out inside of that final impression. And again, since there's no reseating of the impression copings back into the impression material, you're pretty much guaranteed that you're going to get a nice, accurate result. And I get a little bit nervous sometimes with the closed tray, which is why I prefer doing it this way. And then you'll place the healing caps or healing abutments back onto the implant. Then at the next appointment, once we've had the opportunity to pour up the master impression, place the analogs, and get the locators in place, we will send you a bite block. And again, this will have the black processing non-retentive caps on the inside. You can see those caps are hollow. When you see one of the regular retention caps, they have an island in the middle because they have retention on the middle and around the outside as well. But this is the bite block, and so you are going to remove the healing abutments from the patient's mouth. And on this master model, you're going to see the locator abutments that will be screwed onto the implant and place them on the same implant as they are on the master model. There's differing heights to these locator abutments, so depending on how deep the implant was placed, there's going to be different heights on these to try to get them as level as possible. So we'd like to have all four of these as parallel as possible, and we'd also like to have them as level as possible. And so make sure you use the right one for the right implant. And this is what that bite block looks like from the outside. So you can go ahead and take the core tool and put the locator abutments into the implants. You don't need the torque wrench for this. You can just kind of hand tighten it down. And then you're going to make sure that the bite block seats onto those locator abutments. And once it does, this is your opportunity to move the two centrals around. And if you want to change the lip support or lengthen the teeth, you can see we have some notches that are cut into the bite block for when we're ready to take the bite registration. So basically, you're just going to go through all the regular steps that you would for a denture setup, checking the S sounds, checking the F sounds, and getting your vertical and all that good stuff like you normally would. And then do your bite registration with the opposing. And if you want to, you can also do, something that we used to do or still do with veneers, which is showing the bite plane to the technician by paralleling this with that interpupillary line. So you can add a little more bite registration if you want and put a stick on there. And then you're going to send this back to the laboratory with whatever shade and whatever mold you want to work with. If we're going to duplicate the patient's existing denture because they like how that looks, you send a study model of that so we're able to do that. And send that all back with the locator abutments unscrewed back on the model again. Put your healing abutments or caps back on again and send it back. And then you can see we've actually fabricated this denture, and it's now ready to be tried into the patient's mouth. So on that next appointment, you're going to remove those healing abutments, and now you're going to put the locator abutments into place in the patient's mouth. And this time, because this is for permanent, we're going to use that same core tool from Zest Anchors. And by the way, if you go to zestanchors.com, you'll notice that they have a lot of good articles and they've got a lot of good videos outlining this whole procedure as well if you want to see it more. And they're the ones who manufacture this. And they have a torque wrench that you're going to use to place these for the final time at 30 Newton centimeters to place these down into the implants and make sure that they're good and tight. And then we're going to take the denture itself and try it back into the mouth now that it's been processed, and snap that into place. And again, it depends which cap you want to start with, how much retention you want. I recommend the blue with the extra light retention, the 1.5 pounds of retention, because that seems like a good place to start because it's a nice light, but it still has enough grip where they're going to notice the difference, but it's not going to bend or break fingernails as they go to take it out. And you can always go up if they need more. And we can see here's the patient now with the denture in place, smiling and happy because it's locked in, and you can actually hear the snap as it goes into place, much more so with the blue retentive caps than with the black processing caps. One other thing to keep in mind while using this locator system is that it can also be done with a bar, with a milled bar. And so you'll notice we've got 4 implants here and 4 locator abutments as well, but we've also got this bar. And the milled bar really does, it's not that it does much for the retention of the denture. It's still the same type of 4 locator attachments as we have here, but really it's the stabilization of those 4 implants, and it really bodes well for the long-term prognosis for these implants when they're hooked together with this bar. So if I had my druthers, I would do this on every case that I could, but it ends up costing the patient more, as you might imagine. You know, this is probably a couple $1,000 lab bill more because of that milled titanium bar. So the price to the patient goes up. But this, in my mind, would be the Cadillac treatment, and this would be, well, I shouldn't say Cadillac. Let's call this the Mercedes-Benz treatment. Let's call this the Chrysler 300 treatment, just because I had one of those. And then let's call a lower denture with nothing in it the VW treatment, and because that would be kind of our one position we didn't want to take. The cheapest way would be to have no attachments, and then 4 locators by itself would be the next, and then the best would be the 4 locators with the bar connecting the implants for the overall longevity of those implants. But of course, it also increases the vertical hair too, so we may not necessarily have room for this as well. It adds about another 2.5 millimeters to the height of that bar, and we need a couple millimeters for that bar, whereas just the 4 locators by themselves, you can see how nice and low profile those are. When those retentive caps snap onto there, we'd like to have about 1 millimeter of space between the cap and the gingiva. So I've had cases where I've removed like old ball attachments that have been on the implants, and they were much taller, and by the time we put the locator abutments on, we gained 1.5 millimeters, sometimes 2 millimeters of space, which can mean the difference between a broken overdenture and a not broken overdenture, for one thing. And so you can see nice low profile along here as we look at the locator attachments. And that's why, because we need the differing heights, and they're for different implant systems. So obviously you need to let us know what implant system you used and what diameter it was. And then we'll go ahead and we'll pick the locator attachments and their different heights. They come in 6 different heights so that we can get these as level as possible going across this way. We want that to be a nice level plane as you go across. So when you do take out old attachments, for example, I can think of a couple patients who had some ball attachments for a lower denture. We unscrewed those ball attachments, and then we screwed in some of that. Well, let's say we're going to retrofit a denture and take out the ball attachments and switch over to something like we have here with the locators. The first thing we're going to do is create some space in the denture. So we'll prep around the old housing that's in there for the ball abutment, and then pop that out, and then just route it out a little bit more around that. If anything, we want to create almost, too much space here, because our locator housing that's going to sit on here needs to go inside of here, and we need to leave some room for the resin that we're going to cure it in with. So we're going to just hog it out a little bit with a burr around that and take the old housing out of there. The other thing we're going to want to do to make sure that we don't force this resin where we don't want it to go is we're going to place a lingual channel. So once let's say we're just doing these 2 right here, pretend these 2 don't exist, we route this out and hollow it out to make room for the new locator housing, and then we're going to turn the denture, and seeing where that hole is, we're going to drill a channel here through the denture and one here. We want a relief or escape channel for the resin that we put in, somewhere to go besides being pushed down around the implant itself. So once we've done that and kind of hollowed it out, we'll try it back into the patient's mouth, and we want to make sure it's a passive fit. We want to make sure we've removed enough acrylic so we're not bumping into our locators. Once we know that we've done that, then we're going to place a white blockout ring. It's a little ring, looks like a little O-ring, that's going to sit right around the locator, and what it's going to do is make sure we don't get resin down around the implant as we reline this. So we put the little white blockout ring on these 2 and put it down into place, and then we'll take that black cap, the one that you see right here. It wouldn't be in here at this point. We would have taken out the old housing that was in there, and we'd take each of these 2 black caps and pop it down onto these 2 right here, and it would be sitting down on top of that ring. So we'd have our black cap here, and then we'd have the white O-ring right around at the gingival level. And now that the housings, those black ones, are in there, we would try in the denture one more time just to make sure it still passively fits, because we've added a little vertical height here by putting the black cap on. And as long as it seats passively and goes over well, then we're ready to get started. So we'll sandblast the inside of the denture in those 2 areas. We'll place and I just use like a little micro etcher. We'll place some bonding agent here, the Triad VLC, Visible Light Cure Bonding Agent, into these 2 holes, air thin it, then we'll cure it. And then we'll come back over here to the little housings, the black housings we're going to pick up. And we will place a little light cure over on both of these as well, air thin it, and then cure that. And so now we have bonding agent here on the inside of the denture. And then we'll use that triad dual line, dual cure denture resin. Looks just like an impression gun. And we're just going to squirt it through the tip. It looks like an intraoral tip, just like we would use for a polyvinyl siloxane impression. And we're going to squirt our resin into each of these. Into each of the, obviously without the black cap there, and then seat it down into the patient's mouth. And as we push it down into place, we're going to have the patient bite together lightly. We do not want the patient to squeeze really hard. If they squeeze really hard, it's going to bottom out the denture on the top of that, and we'd like some resin on top. So we just tell them to bite lightly down onto that. This is not a squeeze as hard as they can. And obviously we won't be able to see it, but some of the excess resin will come out of these lingual channels as they close down. And we can take our light curing unit and start to cure it from the facial. You can cure through the acrylic, but we'll still wait the 5 minutes for that triad dual cure to go through its complete chemical setting reaction. So once it does, then we'll take out the denture after it's been 5 minutes, and we'll notice that the blockout rings, those little white O-rings that we had here, are now going to be stuck to the inside of the denture. So we can pull out those two little caps there and see if we have any voids. We might have a little void. We might have a little rough area there where we can go with a burr and smooth it off. And if we have a void, we can just squirt a little more of that triad dual cure in and then use a micro brush to kind of shape it into place. And then cure that again and make sure that's nice and smooth. And once we've done that, we use that core tool from Zest Anchors to take out the two black non-retentive ones, unscrew the attachment, and you'll take those blue caps and snap those back into place. And then at that point, we're ready to have the patient try it back in. We just need to flip it over and polish the channels where we had the excess resin coming out, pop it back in, and see how the patient feels with those blue caps. Most of the time, it'll feel fantastic, and they'll be ready to take it home and wear it for a week before they come back for their first post-op appointment. So that's a very quick overlook at how we're going to do an implant overdenture utilizing a locator attachment from Zest Anchors. And again, at zestanchors.com, this company does a great job of education if you want to see some more detail on the clinical procedures for both of these techniques.
Now let's go to a segment we call Viewer Mail. This week's viewer mail comes to us from Dr. Nathan Robison, and he's got a 3-part question and writes, "Hi, Dr. D and Megan. I think I may be approaching Chairside Live groupie status. I really love your show and have taken home some real nuggets. Thanks for the entertaining and informative episodes. It makes the commute enjoyable." Well, thank you. So here goes his questions. He says, "I have some concerns about zirconia that I would like to ask about. Number 1, I've heard that one needs to be careful adjusting full contour zirconia after it has been sintered, as this can initiate micro fissures and cracks that can ultimately lead to failure of the crown. Is there any truth to this statement?"
Well, Nathan, thank you for writing in and thank you for watching all the time. But actually, to become a groupie status, you would need to show up here and wait outside the studio with some delicious churros, like the real CSL groupies do. But we'll consider you an at-distance groupie, if you will. Yes, you need to be careful when adjusting zirconia. If you walk through the laboratory here, you'll notice that all the technicians who are actually adjusting zirconia are doing it with a handpiece with water turned on. And they're always using water. They've got little, vacuums right in front of them that clean up the water. And you don't want to raise the temperature on the surface of that zirconia. And it's pretty easy to lean in with a burr and get that temperature up to about 800 degrees. Above that, it starts sparking. You've probably seen that before if you've ever tried to cut it off. But most dentists, they'll mark the bite with some occlusion paper, and once you have the spots on the teeth and they go in and adjust it, they don't really want to do it with the water on and mess up all those spots. Not that you mess up the spots, it's more about getting everything wet now. Now you've got moist cotton rolls that you have to take out and replace them with dry ones, dry everything off and check the bite again. So most dentists that I know, if not all of them, adjust zirconia without the water on, kind of like they used to all other materials like traditional feldspathic porcelain materials. So if you're not going to use it with the water on, which is the best way to do it, but the least convenient way to do it, keep the air on, obviously, even if the water's off, and use just very light touches as you touch it. I've got a Cavo Electrotorque handpiece, and so I'm able to turn the speed way down and adjust it, hopefully not creating as much temperature increase as I would if I had it turned way up. So if you're not going to use water, use very light touches. Don't just lean into it and start going back and forth. That will, in fact, increase that surface temperature. And so the best way to do it is to use water. So if you can use water and you can handle it and you have the patience for that, absolutely do it. If not, leave the air on even though you turn the water off and use very light touches.
Great. He's got a follow-up question to that first question. He says, I've heard that if you do extensive adjustments on a zirconia crown, it is possible to refire the crown and it repairs and realigns the crystal lattice of the material. Is there any truth to that?
We've never been able to demonstrate that here in the laboratory, and we've tried it before. And we've also tried it where we played around with firing cycles on the oven, so sometimes we'll get something that's a little under-sintered, a little underdone, if you will, and we'll try to put it back into the oven and bring it the rest of the way, and it simply doesn't happen. So if a dentist does do extensive adjustments on it, typically they'll send it back to us maybe to be reglazed, and we'll reglaze it, so we'll run it up to that temperature, but that's far from the temperature where it's sintered, so it's not going to help that crystalline structure at all if it's been extensively adjusted. If it's been extensively adjusted with the water on, without some really hard strokes, then it's probably going to be okay. But the truth is, if you have to adjust it extensively, you're probably better off, let's say the bite was off, you're probably better off taking a pickup impression, sending it back to us. We'll just mill you a new one with that new occlusion on it so that, you don't have to go in and adjust it anymore, but we don't have a weakened crown. We would rather just start off with a new crown. Or if it was on an anterior tooth, and you did a bunch of adjustments to it and sent it back to us, we would scan that crown and use that as our new file to mill the new one rather than trying to heal it in the oven. We've never been able to prove that that actually works.
Okay, and then his last question says, so we think that zirconia can be bonded, kinda, sorta, maybe, but for all intents and purposes, retention and resistance form are still very crucial to Bruxer's success. Am I correct? What can you tell me about bonding zirconia with a resin cement like Reliax Unisem or Multilink?
You are correct, sir. Yeah, you're absolutely correct. I mean, like with any crown preparation, mechanical retention is what it's all about. Retention, resistance form, keyways on the top for really short crowns. But you can actually bond it into place. It is possible to do, but you need to make sure that, first of all, you decontaminate it. So after you try it in, you either go on a sandblast the inside of the Bruxer crown or use the IvoClean on it to get rid of the salivary phosphates. And once you've done that, you're going to place a zirconia primer, which would be something like Z Prime Plus from Bisco, or you could use Monobond Plus from Ivoclar. And then the two resin cements you mentioned Reliax Unisem and Multilink Auto Mix. Those are two different levels of bonding. So the Unisem, kind of like the Maxim Elite, is a self-adhesive resin cement. You'll get a stronger bond to the tooth, but the same bond to zirconia to go to something like Multilink Auto Mix or Panavia F 2.0. Those are both self-etching resin cements with a separate self-etching primer. So you'll get a stronger bond to the tooth even though you'll get the same bond to the zirconia. So if you remove those salivary phosphates with the sandblasting or the IvoClean and then place one of those zirconia primers like the Z Prime Plus or the Monobond Plus, you will in fact get that resin to bond to the Bruxer crown. But is it going to be enough to overcome, a 2 millimeter prep that's got convergence angles of 45 degrees? No. So we still want as much mechanical retention as possible, crown lengthening if necessary. I go to this bonding protocol I just mentioned anytime we've got a clinical prep height of less than 3 millimeters or if it's tapered more than 15 degrees. So that's something to keep in mind. So we can bond to it. It's not that we can't bond to it. We can bond to it. It's just not a really strong bond. But anytime I get into one of those shorter preps with over-tapered walls, I'm going to definitely bond it in place either using Panavia 2.0 or the Multilink Auto Mix after I've decontaminated the inside of the crown and placed a zirconia primer. So we can bond to it, but not the strongest in the world. Don't forget about mechanical retention. As I was taught, and I think most dentists were in school, The cement is the weak link in this whole thing. We want crowns that are almost straight up and down.
And there's the answer to your questions, Nathan.
And you know what?
What?
I think Nathan deserves, since we talk so much about adjusting zirconia, a Bruxer adjustment and polishing kit.
You're so generous.
What could be more appropriate for that kind of question, a 3-part question?
This photograph?
Oh. Let's read our moods. Every week we can read the moods of what's going on.
And this is I like to call this my Twilight shirt because it's kind of like it brings you into the Twilight Zone. It's known to induce hypnosis because it's kind of like...
That's true. I remember being hypnotized after last episode and almost getting in an accident on the way home.
That's scary and not true. But yeah, no, we both just kind of blank stares on our face, so I don't know what's going on, but...
Looks like we were bored with the show.
I hope
that
not.
Was the truth, but...
Right, and so we'll sign this, and then Nathan can hang it up in his practice.
You're right. Well, he watches the show while he commutes. I don't know if that means he drives the car and watches it.
Let's hope not. Please don't be doing that.
You think he takes the train?
Yes, I do.
Okay, there's probably about 4 dentists who take trains to work, and he must be one of them.
Just pretend it's him.
That's right. Any news?
Yes. A New York orthodontist was sentenced to more than 8 years in prison for filing fraudulent tax returns and was ordered to pay $200,000 in restitution. The man filed 5 years of false federal refund claims, including a 2008 claim for $35 million. He also tried to evade payment of taxes he owed to the IRS. A federal investigation began in 2010 when federal agents traced threatening letters sent to governors by the doctor, telling them he was a part of the sovereign citizen movement, a group that thinks U.S. tax laws don't apply to them. He even taught seminars and gave internet radio talks on how to avoid paying taxes.
I used to have a patient who was very into this movement.
Are you serious?
Yeah, and this is all he wanted to talk about every time he came in was, it doesn't say anywhere in the Constitution that we have to pay taxes. This is totally illegal. You can do this, and he'd say things like, I haven't paid taxes in 7 years. Look at me. I'm still free. Things are still fine.
Okay, well, just wait, because he's probably in jail at this point.
I like, though, that he filed that 1 year and asked for a $35 million
refund. I mean, so much for being subtle.
I think that'll get a red flag to go up.
Yeah, maybe.
Yeah, I know. I see doctors who write off their car payments because they drop off cases here at the lab. That seems like a red flag, let alone asking for $35 million back.
Yeah, but he was... there was the trial in October of 2013, and then he was just sentenced just now, so...
Perhaps there is something that says we have to pay taxes.
Perhaps.
Maybe it's not in the Constitution, but I don't think there's anything about the speed limit or things like that in the Constitution. I think there's other rules, laws we have to follow with the threat of imprisonment that aren't necessarily in the Constitution.
And I'm just wondering if all those people who took his seminars and listened to his radio talks are coming asking for their money back.
Right.
Sorry, I don't think you're going to ever get it.
Maybe he was asking for the $35 million on their behalf. He was going to distribute the wealth back to the people.
That kind of stuff is just mind-boggling to me. Wow.
Right. I would have said, when the patient used to come in and say that to me, I would have thought there's no dentist who would ever do this because we tend to be conservative by nature, and it's just kind of like, I don't know, that's just a lot of exposure. I'm surprised he did that.
Well, yeah, well, you're right. He's an orthodontist, so hey.
Right. Anything else?
Yes. Wichita Falls, Texas is suffering the worst drought on record, so severe that it is about to become the first place in the U.S. to treat sewage and pump it directly back to residents. The city is awaiting final state approval to begin recycling 5 million gallons a day starting in May. Officials say all traces of sewage will be removed, but residents aren't so sure. And it's not just Texas. Cities in California, Florida, and North Carolina are also considering direct reuse. But why sewage? With 2/3 of Texas in drought, city officials say it's faster and cheaper than building reserves or drilling wells. The city has banned outdoor watering, prevented golf courses from using public water, and next step, residents will not be allowed to fill their swimming pools. The application is pending as officials review filtration and testing systems. Federal approval is not needed.
So they take the sewage. Right. And do you know how they treat it?
Yeah, they first remove the solids, which that in and of itself just, I almost want to just stop there.
Right.
Because you're removing solids from the water I'm going to drink. But they remove the solids, and then it goes through a chemical process to remove any of the contaminants. And then fluoride and chlorine are added, and then drink up. Are you serious? And then they said, And I feel bad for Texas. This drought is the worst it's been in 140 years.
Right.
And recorded, for as long as they've been recording rainfall, this is the worst. But it's moving into cities like California. Oh my gosh.
It's funny. You know, the word solids doesn't get used all that often, except in that context. It's like the other S word. And because you never hear solids referred to,
Right.
you know, unless it's something like that, which is odd. But I think I remember seeing on one of those Survivor shows that a guy was living like drinking his own urine.
Yeah, the astronauts.
But this is other people's.
Right.
Right. A lot of other people's.
Yes, and the astronauts in our space program they had a filtration system to switch their urine to drinking water. That's one thing. It's another thing when we bring solids into the mix, okay? When we've got solids in the mix.
Well, that's awful. Let's
Yes.
hope it works out for them and they get some rain soon.
I know.
And let's wrap this up. I'd like to go have a solid lunch soon. So
Ew.
that about wraps it up for this edition of Chairside Live. On behalf of everybody here at the laboratory, the CSL crew, Megan, and myself, I want to thank you for your time and your continued commitment to quality dentistry.
We'll see you next time. I have to eat by 11. I got a glucose test. Choked on some solids over there.
On the case of the week,
Would you stop with that bite? How do you do that? I can't do it even if I tried.
it's from years of showing patients how to. When you ask them to bring their teeth together, they do what you're doing. You're like, you need to bring them together so I can see the spot.
How do you do it? Ooh, I'm ready. Minus the Parker hair on me. Thanks for the entertaining and informative episodes. It makes the commute and start over.
Yeah, it's funny. You know, the word solids doesn't get used all that often.